Thank you very much. I shall be covering disruption, telemedicine and equity in the context of HIV services during COVID-19. These are my disclosures. And this is what I shall be covering, each of those three elements, and then some closing thoughts. So firstly, disruption. Now, thankfully, things were not as bad as initially predicted. So early in the COVID-19 pandemic, UNAIDS and WHO undertook some modelling work looking at the impact of antiretroviral interruption on AIDS-related deaths in sub-Saharan Africa. And what we see here up to 2018, that decline in AIDS-related death, but depending on the degree of treatment interruption, you can see quite alarming numbers of excess deaths from 110,000 with 20% coverage interruption to more than double, an additional 560,000 AIDS-related deaths if interruptions were 100%. Now, as it turns out, things were not so bad. So this was an interim assessment from the WHO produced in August 2020, followed by an updated pulse report published in April 2021. And this is a national survey of many countries looking at the impact of COVID-19 on various services. In terms of HIV services, nearly half the countries included in the report described disruptions to testing and prevention services, but a lesser degree to treatment services. And the difference between the two time periods was quite marked in that the percentage of countries reporting an impact on HIV treatment declined from 31% to 17% from 2020 to 2021. So prevention and testing impacted more by treatment, but clear improvements as the pandemic progressed. This additional report from the Global Fund published last year, looking again at the impact of COVID on HIV treatment, shows reassuringly that treatment cohorts were largely maintained and that those treatment programs proved to be more resilient and more adaptive than expected. However, they did flag the severe reduction in access to prevention services and some of the disruptions to testing and treatment initiation. We don't yet fully know the impact, and they could have a dramatic effect on the progress made globally in terms of ultimately reaching zero new HIV transmissions. Now, it's impossible to generalize, and each country would have had very different experiences, and within each country, different regions and different groups of people would have had very different experiences. But in general, as perhaps would be obvious, interruptions were worse in low and middle income countries. Outpatient services were most impacted, and naturally, as you would hope, emergency care was prioritized. But what we all have a role for is to ensure that HIV treatment is prioritized, that HIV treatment services are considered crucial, not just because of the individual health consequences, but of course the public health consequences of antiretroviral therapy interruption. And certainly for us in the UK, we produced guidance. This was an updated version during another COVID peak, making sure people had the agency and had the information to ensure that they were able to negotiate locally to make sure that HIV treatment services were maintained and considered a priority. So secondly, telemedicine and other solutions. So we were all required to make very rapid, very unplanned changes to our services. I've mentioned that the impact of COVID was very variable globally, and we're only just starting to count the costs. And it's going to be many, many years before we fully understand the impact of this pandemic on care in general and, of course, HIV outcomes. Unusually, certainly for us, we are very careful to engage with service users when we're making changes, but we really had little choice than to make rapid and pragmatic decisions. However, it's a direction of travel we were already moving in. So in terms of using telemedicine, which broadly includes telephone, email, and video appointments, certainly here in the UK, it's something that we were moving towards slowly, and COVID has really accelerated us embracing non-face-to-face ways of managing care. Now, I think some of the key things to think about beyond telemedicine per se is accessible information. Lack of clear and reliable information drives anxiety. And just to give you a couple of examples of what we did, so locally we updated our website, we used text messages, and we have a system where we can text our entire cohort via our electronic patient record system. And we bought a new, very cheap mobile phone, advertised that number on our website, and that was used a lot by patients unable to get into clinic, not necessarily able to get advice through the usual routes, and they were able to phone and speak directly to a doctor. Regionally, we held regular meetings across London that provided two roles. One was to sort of share policies and procedures, make sure we were sharing access. So, for example, making sure people knew that if a patient at their service needed an emergency prescription, they were welcome to collect that from another clinic. But also for us as staff, just to have that check-in and that ability to share concerns and fears with other people was invaluable. And then at a national level, mainly through work with the British HIV Association, we developed guidance. I gave you one example earlier. We produced a lot of policies around COVID care, vaccination, etc. Clear patient information in collaboration with community groups, and also promoting and leading research and audit to guide our guidelines, and ensuring that HIV services were represented across medicine when decisions were being made at national level. Pragmatic monitoring, and I think one thing we've learned is a lot of the monitoring we do is out of habit more than necessity, and I think we will learn a lot from COVID about what monitoring really is essential. But of course, monitoring is not just blood monitoring and laboratory monitoring. It's monitoring mood and ensuring that even if we're using virtual consultations, we're making sure we assess people, because we may be missing some of the non-verbal cues that may alert us in a face-to-face setting that somebody is suffering. The other issue is things like domestic violence, which we know disproportionately impacts women living with HIV. This is an example of a hand signal promoted in Canada that's been employed globally as a way of communicating that somebody may be experiencing domestic violence at home. But again, ensuring that if we aren't seeing people face to face, that we have the mechanisms to capture, report, and support women who are experiencing this is absolutely essential. And of course, maintaining antiretroviral therapy. Now, that may be about giving longer prescriptions, although of course we must be cautious about ensuring we don't damage supplies. But it's also about new mechanisms, delivering medication to home. And that's something we already had in place in the UK, but we rapidly shifted to posting medication for almost all people in our service, so they didn't need to leave home in order to access their usual treatment. But also keeping calm, as I alluded to, panic prescribing, and understandably people feeling anxious and wanting to have a stockpile of their medication, ensuring that that's managed very carefully, because many of our supplies are relatively tenuous. So clear communication and ensuring clinicians are reassuring patients about supplies is an important part of antiretroviral therapy maintenance. And some silver linings. There's always a silver lining in almost every cloud. So this is some data from the recent CROI conference, and this is looking at a San Francisco cohort, and they actually showed better rates of viral suppression during COVID-19. So this graph here, in a cohort of just over 1,800 people, shows a mean viral suppression rate prior to COVID of 84%. And although it dipped very initially, after the first period during COVID, the average suppression rate improved to almost 88%. And that's due to employing virtual technology, phones, etc., to better access people and engage them in care. The other thing to think about is that we know that geography can be an important barrier to access care. These are just two examples of studies from Africa showing that travel distance is greater for people with HIV than with other medical conditions, driven by access to antiretroviral therapy in different centres. And there's a relationship between the maximum achievable ARC coverage and the minimum travel time to the nearest healthcare facility. And that Malawi paper concluded they'd never reach the kind of UNAIDS targets if that barrier was not addressed. And clearly here, being able to offer people virtual consultations and delivery of medication and removing that transport step could be helpful in improving outcomes. Thinking about women specifically, this is a paper published this year looking about some of the health and social issues impacting women with HIV. And these are just some of the quotes from this qualitative research. Caring for dependent children, parents or relatives, travelling long distances, not just the time, but also the travel costs. These were all described as potential barriers to accessing care. And clearly these are all things which may be improved if virtual care is employed by not needing to travel to a clinic. This may have an impact on some of those barriers disproportionately experienced by women. Thirdly, equity. Now let's start with this. I've shown you that viral suppression actually improved during COVID-19, but much like a lot of research in HIV, women were underrepresented, and here just 12% of that cohort were female. And making sure that we're monitoring outcomes and looking at the groups who are not being so well served is really important. When we think about some of the key considerations for virtual care, firstly, the feasibility, hardware, software. Now, we know from global reports that women are less likely to have access to mobile devices than men globally, so they may be particularly underserved by services that depend on access to the appropriate hardware and software. Privacy. There was a survey in the UK that showed that 1 in 20 people did not have a private space at home to have a virtual consultation. And when we're thinking about women who may have families, shared accommodation, or who may be experiencing domestic violence at home, again, that could particularly impact them. And language, and ensuring we use proper translation services, because there's a lot of evidence that things like Google Translate are not accurate. There's the suitability, whether someone needs a physical exam, whether they need multidisciplinary team input. And again, with women disproportionately impacting mental health issues, we may need to think about how suitable they are for virtual care. And some of those opportunistic activities like cervical screening may be more challenging to implement in a virtual world. And finally, preference and patient choice. And I'll come on to a paper in the next slide about women's preferences, but we must ensure we offer people a choice. But one thing I would say is prior to COVID, our virtual clinics were very unpopular. And when we undertook a survey after we started using more virtual care, or almost exclusively virtual care, a number of people expressed that they would prefer to continue their care in a virtual way afterwards. So actually, sometimes trying a new way of accessing your care means you may actually find it's not as bad as you previously thought. And this is some data from Atlanta looking at patient experiences with telemedicine for HIV care. Overall, patients expressed concerns about the lack of physical exam and lack of laboratory testing, but women expressed greater concern than men. And the two particular areas were around physical exam, but also more concern about safety of their personal information. And that's been shown in other general population surveys in the US. So clearly this is where we must play a role to reassure people around confidentiality, to reassure them that in many situations a physical exam and laboratory tests may not be necessary. This paper concluded that strategies to address concerns with telemedicine are required to promote retention, and they will likely require different approaches for men and women. I just wanted to touch on this. This is some evidence pre-COVID from non-HIV care. It just highlights that face-to-face consultations are better for a first meeting because people are more likely to trust someone they've met in person before. And for complex and sensitive problems, face-to-face remains preferable. And finally, my closing thoughts. So women must be included. So whilst COVID has granted many of us a clean slate as we redesign and adapt our services for the post-COVID era, we must make sure we measure women's experiences and outcomes, and we listen to what they want and need, because it may differ from men. But what we must remember is there are many deeply ingrained, long-standing reasons why we see inequitable health outcomes, and the social determinants of health are so important. COVID has highlighted that all the more, and understanding that many of these disproportionately impact women is crucial. We know that issues like systemic racism, we know issues like the fact that people with HIV come from communities and populations already at higher risk of poor health. These are things we must consider, but we must also recognise that medicine will have limitations. We must ensure we measure outcomes and ensure we offer equitable care where we can, but we must also lobby for the societal and political change that will be required to truly ensure all people are treated equally. I shall finish there, thanking you very much for your kind attention.